Hi, my name is Tom Chilimsky. I'm a neurologist and I specialize in the management of chronic pain.
And my name is Jeff Janata. I'm a psychologist who's trained in medical psychology and has emphasized treatment of chronic pain for most of my career.
Hi, I'm Elizabeth Lane, a physical therapist. My research focuses on pain neuroscience education for those in chronic pain.
And my name is Gisela Chilimsky, and I'm a pediatric gastroenterologist that works in chronic pain in adolescents mainly.
This particular workshop follows workshops A, B, and C that were targeted at helping physicians learn the biopsychosocial approach to chronic pain. We're now turning our attention to psychologists and physical therapists. Their training, their background training is different than physicians. They have other tools available, and yet their tools may not be complete enough to really address all of the issues that occur in a patient with chronic pain. So in our next few videos, we are going to address how to complete that training, that set of skills, in order to fully address the issues that are brought by a patient who has a significant chronic pain syndrome. Today's module is about how a physical therapist and how psychologists address a chronic pain syndrome. For this purpose, we've brought in an expert physical therapist, Elizabeth Lane. Elizabeth, do you want to introduce yourself?
Hi, I'm Elizabeth Lane, a physical therapist. My research focuses on pain neuroscience education for those in chronic pain.
So we'll ask you some questions right now, but we'll start with Jeff and then see what we do in physical therapy. So Jeff, when you see a patient with chronic pain or a chronic pain syndrome and you are not a pain-informed psychologist, how is the approach versus the approach that a pain-informed psychologist would have?
Typically, psychologists are trained in traditional mental health kinds of presentations. So we have training in how to assess and treat mental disorders, depression, anxiety, and so forth. In the case of someone who has chronic pain, we need to expand our sense of our focus beyond comorbid mental health kinds of accompaniments to chronic pain to look more deeply at factors that may be either contributing to the onset and development of pain, or are maintaining that pain, or are consequences of pain, all in the context of understanding from a phenomenologic perspective what a patient who has chronic pain is experiencing and how that chronic pain may be maintained.
Would you expand a little bit more? Which are those things that you're looking? And I'm sure that they overlap with some of the things that we discussed in the previous modules, but I think that would be nice to kind of refresh.
So, well, let's take the example of someone who develops a chronic back pain condition. Under those circumstances, there may be an injury to the back, and then there is some persisting musculoskeletal injury and damage. As a consequence, some of the aspects of that patient's life are affected. They may become demoralized about their inability to function. They may become anxious about hurting themselves in the context of trying to be active with pain. This then begins to not only affect their psychology, but it starts to affect their relationships with other people. Perhaps they're not earning the income that they were earning before, and that has an impact on the family. And so a pain-informed approach is likely to take, really should take, a longitudinal perspective where we look at the variety of factors that bring to bear on a patient's experience and factors beyond that initial musculoskeletal kind of injury that may be contributing to the maintenance of a chronic pain syndrome.
Thank you. I think that was very clear. Elizabeth, would you share how is it with the physical therapist? How does that work?
Sure. So as a generally trained physical therapist, we're used to dealing with pain, which is the primary reason that someone is referred to us. So generally, we'll take a look at that body part very specifically. So we take a look at joint mobility, range of motion, muscular endurance, muscular function. In those, and there are common themes throughout physical therapy where we take a look at functional limitations. That's always our focus. And then we look at what barriers there are to reaching that person's function. In those with acute pain, it's usually something like the muscles aren't firing well, the joints aren't moving well. In the case of chronic pain, however, the mechanism underlying that is much less in the joints or in the tissue that we're really looking at, and much more centrally driven. So we have to explore the reasons why that pain may have persisted. And that may mean that we uncover some fear of movement, some anxiety about movement. We may uncover that the person just has a different sense of what's causing their pain than what actually is causing their pain, and that they're hyper-focused on certain pathoanatomical terms like a tear or a disc bulge. So we really have to dig down a lot deeper into the reasonings that the pain has persisted, and then our treatment would be directed at that.
Elizabeth, to follow up on what Gisela just asked you, are there certain guiding principles that you utilize then in a patient who's got a chronic pain syndrome as far as how you approach them and how you decide which particular therapy might you introduce first and second and so on?
Mm-hmm. Well, not specific to chronic pain. We have a clinical practice guideline published by the American Physical Therapy Association for those with lower back pain. Okay. And really the first step in that is to assess biopsychosocial risk factors for developing persistent pain. So if that person does demonstrate medium or high risk of developing persistent pain, then we really need to address those biopsychosocial factors prior to continuing on and taking a look at local tissues such as the lumbar spine.
So what is that particular assessment of low, medium, or high risk? What does that look like?
So that is primarily assessed with the START back tool developed by a physical therapist, Hill, and it's a 7-item, I believe, questionnaire that asks the person about pain that they've had over the past 2 weeks. Has that spread to their leg? And then asks some psychosocial specific questions. How worried are you about that? Do you fear that your back pain may persist?
So is that a tool you recommend all physical therapists use if they're treating chronic low back pain?
Absolutely. It is a very, very quick tool, and it has just been shown to be responsive throughout treatment, so it can be reassessed. It's not only a screening measure when they come in.
So it seems that a lot of the questions there would apply to other pains too, maybe not the radiation of the pain, but so do you use it also in other kind of pains besides back pain?
We don't. It is fairly specific to the lumbar spine, but the questioning can be adapted to other body parts, easily the cervical spine.
So Elizabeth, let's say you determine somebody is low risk, how do you approach them? Medium risk, how do you approach them? And high risk, how do you approach them?
Good question. So for those that are low risk, they continue with a normal course of physical therapy, perhaps even a shortened course of physical therapy, where we evaluate them, give them a home exercise program, and then may follow up some extended period of time down the road to decreased healthcare utilization. And those folks really recover well on their own and don't need a lot of intervention. For medium and high risk, I'm going to sort of put those together because we need to take a deeper look at the psychosocial factors that may be playing into or posing a risk for developing persistent pain, and that may be some abnormal beliefs or fear of movement, and those things can be quickly addressed in those with acute pain and not allow that to become persistent pain. But it certainly will become a much more extensive process where the chronic pain syndrome has already developed. So we really have to take a very much more pain-informed approach.
Gotcha. Okay. And so I assume some of the comorbidities might also be anxiety or depression.
Absolutely.
And how would you identify those, assess them, and what would you do if you did identify them?
Well, luckily there's a lot of patients that come in that have already been diagnosed with this. So if they indicate that on their past medical history sheet, then we certainly do ask about that. How have you been managing that? How do you feel like you're managing that now? So that's a different conversation. For screening for that, we use a depression screener question. So in the past month, have you been feeling down, depressed, or hopeless? Or have you found little interest in doing things that you previously enjoyed? And if they answer yes to either one of those, we can follow up with, would you like help with that? And then, you know, there are certain red flag conditions if the person is considering harming themselves, but that's fairly rare that we see that sort of thing.
So I would imagine that if a patient answers no to the question, would you like help, that's going to make your job more difficult.
Sure.
How do you have any way that you handle that to try to help them move in the direction of being willing to accept help?
Mm-hmm. Slowly and tactfully, right?
Okay.
So, you know, we first probably need to educate them on the helpfulness of getting some help with that,
Right.
Seeing someone for that. And it may come down to they don't think that it's a problem for them.
Right.
And so slowly through education throughout their physical therapy, we can start to address some of those beliefs. And it may be that they don't believe that any psychosocial factors play into their pain syndrome. And so
Right.
we can use some examples to show them how much that does play a part in their pain experience. And then really we can start to push them towards a professional that can help them reconceptualize some of their pain more appropriately than we're able to as physical therapists.
You know, I think you're in an ideal position
I do too.
because you have the opportunity to see the patients in the context of engaging in activities, and then you can see the workings out of the demoralization that comes with movement or lack of function, or the apprehension and anxiety that comes hand in hand with asking them to engage in a task that they hesitate to engage in. That gives you an ideal opportunity to address those factors. I think.
Absolutely.
Yeah.
And primary care physicians, it's an impossible task to ask them to do that.
Mm-hmm.
Number one, you don't have the time to do that, and you don't have repeated exposure, especially as often as a physical therapist would, to really take those life lessons and help them conceptualize that the way that is appropriate and teach those lessons.
And implicit in what you're saying, it seems to me, is that you have the opportunity to validate and normalize the comorbid demoralization or apprehension or beliefs that may be contributing, and create an opportunity for them to embrace something that heretofore they may not have conceptualized.
Absolutely.
Yeah, good.
And one more step to that would be you can provide very important feedback to the primary care physician about what their life actually looks like, which as a physician, you really never know. You're just basically relying on reports from the patient. Occasionally you have the family, but here you have a professional with objective experience could really provide feedback to the doctor.
Right.
I was also thinking that the fact that you see the patients probably weekly versus us physicians that we see them come back in 3 months, you know, it gives you a relationship with the patient much closer than the physician gets. And probably you would be able to elicit a lot more information than we are able to elicit.
Sure. Yeah, we are able to build that alliance and
Right.
rapport with that patient, and they begin to trust us, and that can help immensely with addressing fear of movement or anxiety about a certain movement or function. And then it becomes very important, as you say, to communicate that back to the physician because they're ultimately seen as the king of the mountain, and if we can communicate that these activities are okay for you to do and we want to follow this program, and then the physician is able to back that up and say, your
Right.
physical therapist is really right on track and you're doing a great job in keeping up with these home exercises or this program, then that adds a wealth of validation that I just can't achieve alone.
So Elizabeth, how is the report that you send to the doctor?
Well, so the electronic medical record or whatever documentation system that you use is going to dictate a lot of that.
Right.
And unfortunately, there's a large emphasis on a lot of surrogate measures for function, like range of motion or
Correct.
strength. And it's just a lot of gibberish that's in there that may not mean anything to the patient or the physical therapist and may not speak to the goals that we're trying to achieve with that patient. So for physicians, it's really helpful to just zoom down to the assessment portion, where the physical therapist will give you a bit of a narrative about what's going on in that visit up to that point in care, where you want to go and how you, and then the next section would be the plan of how you plan to proceed and do you need more time with that patient.
Beautiful, because you are absolutely right. I get the reports and
Sure.
it's the range of motion and, I don't know, ability to stand for 3 minutes. And what I really want to know is what's behind that, right? How are you seeing the progress or what is hindering the progress there? So so I'm going to focus more now on the assessment and plan.
And in the 4PCP program, we're going to recommend that the team have a 2-minute conversation once a week, including the psychologist, the physical therapist, and the physician, which sounds like it may take time, but actually saves an enormous amount of time in the long run.
But I think it comes from the physician too. What do I want you to accomplish with my patient, right? And not just,
Right.
okay, go see the physical therapist. I think that
It's a give and take, right?
Right.
Yeah,
We need to
the physical
improve
therapist
it.
says what's reasonable, what can I get them to, and the physician says, yeah, well, here are my goals, and this is what is really important from my perspective. And I think aligning the 4 perspectives, the patient, physical therapist, the psychologist, and the physician, is really important, because with
Right.
aligned goals, then you can really achieve something.
Well, and if each profession is reinforcing the activities that are taking place in the other professions' arenas, that's remarkably helpful. If there's a
Yeah.
common message, a consistent message, all directed toward the same set of goals, I think that then helps to validate that for the patient and help them understand that this is a set of goals and a set of steps that we're trying to take that all of us can see from each of our perspectives, and
Right.
That adds a kind of gravitas to it that otherwise doesn't accompany a
Right.
single person's.
Right.
And I just
intake.
wanted to make a comment because electronic medical records are a blessing and a curse too, because many times you write a referral for PT and you just put evaluate and treat, and you really didn't give the PT any idea of what you're really trying to accomplish there. So really expanding the text so there is a communication and a team building there.
Right.
Definition of the referral question is really important.
Yeah.
Articulating that in ways that are operationalizable by all the
Totally.
team members, I think, is helpful.
Yeah.
The other obstacle that we confront all the time, frankly, is HIPAA, and we have to
Yeah.
struggle with ensuring that we have patient permission to have these kinds of discussions. Because without that, I think that we're really handcuffed in what we can do with our
Yeah.
patients.
Does HIPAA have particular policies regarding the psychology referral that don't apply to the other healthcare? But my understanding of HIPAA is if you're treating a patient, you can confer with any other practitioner who's treating that same patient without any permission.
And that's not true of psychology and psychiatry.
That's what I wondered.
Yeah, we need specific permission. In fact, in our situation, our notes always are privileged unless we otherwise get patient permission. And so we routinely do that as a first step. And if we get some pushback on that, then that actually raises its own set of questions about
Right.
why there would be pushback. And we can be clear that some aspects of what we discuss are off that record, and you know, sort of what's okay to be communicated and what's not.
Right.
So in the case of a patient who has a trauma history, for example, that really the details of that history aren't appropriate
Right.
To share, but the fact of that trauma might be very important
Right.
to share.
Crucial.
Yeah.
Right. So, Jeff, let's turn to you regarding guiding principles you recommend for a psychologist who's facing a patient with chronic pain. What would you, sort of in a very forest 20,000-foot view, how would you approach, or how would you recommend a psychologist approach that patient?
Well, I truly think that what we're trying to do is understand the various factors that help the development and maintenance of a chronic pain syndrome that are truly different than acute pain. We all understand acute pain. We relate to the idea that there's tissue damage and we have nociceptive input and so forth. But as Elizabeth said earlier, the idea that there are other factors that begin to bring to bear on how chronic pain is maintained and exacerbated over time. And so the principles honestly include, first, understanding the patient's experience and how they understand their pain, the beliefs that they bring about their pain, what they think they know from the physician in terms of what they're struggling with, or what they think they know from whatever source.
And that's, we'll talk about that later, but that's where being pain informed specifically for psychologists is so crucial, so they can relate back to what that patient is relating to them.
Exactly. So it's so one of the aspects of being pain informed is truly understanding, well, what is the medical, the biomedical
Right.
nature of this presentation, and what sorts of treatments have been tried, and what's the patient experience that accompanies those treatments.
Right.
And then understanding in that context how psychological factors, how what I always think of this in terms of what are the contributors, what are the maintaining factors, and what are the consequences. The contributors can include their history, their current experience, the beliefs that they bring. The maintaining current factors can include the psychological and social environment that the patient is experiencing chronic pain in, and the consequences in terms of what factors might be reinforcing pain complaints, what factors might be contributing to pain becoming more and more a central phenomenon, truly, than a peripheral phenomenon.
Such as sleep disruption, depression, anxiety, and a variety of other factors.
Yeah, absolutely. Yeah.